So I think a great place to start is to really talk about where all of this began, which is with cannabis, the plant. Short description there. So cannabis, also called marijuana, these are the dried leaves and stems of Cannabis sativa or Cannabis indica. There are about 2,000 strains that have been named. Um, it's the most commonly used psychotropic drug in the United States after alcohol. So that's really what we're here to talk about today is provide some education about the different strains. And so we're going to go into more detail on that, but just to sort of get us started and level set with what we're talking about.
So Heather, would you like to talk to us a little bit more about why you think it's important for healthcare providers to have these really open discussions with their patients about cannabis use?
So this question is a great one because it really helps frame the discussion that we're going to have today. I know when I was in school in the 80s and 90s, the message was just say no. No education about the substances that were out there, but it was just say no. And that is effective for some people. It was definitely effective for me because it scared me to death. But for a lot of people, and they're especially in groups where higher risks are going to be associated with using something like cannabis, that may not be an effective message. So the goal for today is to really provide some background on cannabis, how it's changed over the years, and talk about the components within cannabis to really help healthcare providers feel more comfortable having conversations with their patients or clients about their cannabis use and help clear up any misconceptions that their patients might have. So we can start with talking about the endocannabinoid system. Cannabis affects lots of different behaviors, and you can see under that third bullet point on the slide, we know it can influence appetite, mood, it has some effects on memory, and cognition is another one that I think we'll probably get into. Um, we have our neurons and glial cells synthesize endogenous cannabinoids. The two that you can see on the right-hand side of the screen are, and it's in very small print, and I apologize, but it's 2-AG, and AEA is also called anandamide. It's a long chemical name, so we call it anandamide. Um, so these are the endogenous cannabinoids that our neurons and glial cells can produce. Our brain and actually in both central and peripheral nervous system express two types of cannabinoid receptors, CB1 and CB2. We know a lot more about the CB1 receptor, possibly because it's expressed in such higher amounts within the brain compared to CB2. But CB2 receptors are becoming an area of interest in the research community because one of the things that was recently reported is that in response to neuroinflammation, CB2 receptors, while they're normally low expression, they can be quickly upregulated in response to an inflammatory signal. So I think we're now seeing a lot more on the CB2 receptors, but our discussion today is going to focus more on the CB1 receptor because this is where the components of cannabis that we're going to talk about, this is what most of what we know about how they have their effects is through the CB1 receptor. And I'll actually turn it over to Dr. McEvoy to talk about the differences. I've mentioned these things, THC and CBD, cannabidiol. He's going to talk more about the differences between the compounds.
Absolutely. Thank you. Again, Dr. Davidson's the scientist of our group, and I'm the clinical guy. But I'll talk a bit here about the neuroscience that tetrahydrocannabinol, the active ingredient causing the mind-altering effects that people seek in using marijuana, acts primarily at the CB1 receptor. It's a psychoactive chemical. It can cause acute, brief, usually transient features of psychosis. Tends to be dose dependent. If you take a very concentrated form of it, you're going to get a bigger hit than if you smoke a bit of a cigarette of a fairly weak marijuana plant. In many people, it can produce some degree of euphoria, but in many, they'll feel anxiety. They'll note some of their cognitive functions are not good, and people will vary a lot in how they receive these effects. The certainly in psychiatric illnesses such as psychotic disorders, affective disorders, there is nothing to suggest that tetrahydrocannabinol is a useful agent, and much to suggest that it may lead to the precipitation of psychotic disorders and other problems in people who are at risk. Now, on the other hand, cannabidiol, the acts much less at the CB1 receptor, and it is more active at the CB2 receptor. And there's evidence that that can even be protective for people. And there are a number of compounds in this group of agents that that are being investigated across a range of indications, from seizures to pain to anxiety, towards some benefit in hospice situations that remain open. There's not strong evidence anywhere for these, but there's tantalizing evidence that these agents may be helpful. I'm sure I've heard in the major news organizations that cannabis in the marijuana that is grown today is very different from what was grown in the 60s and 70s, the heyday of early marijuana exploration. The amounts of tetrahydrocannabinol, which is the CB1 active, the mind-altering component of marijuana, has steadily increased, in terms of amount of that substance per gram of plant. Whereas, sadly, as this has happened, the more protective agent, the mitigating, ameliorating agent, cannabidiol, has declined in its concentration in these plants. And what's also happened is that many more delivery systems, including concentrates as in hashish or resins, and edible forms, which are very variable concentrations, have become available. And especially in previously naive users can give a huge load of tetrahydrocannabinol with very little CBD protective, and can produce unpleasant outcomes. Now, the third group, as I mentioned, there is the tetrahydrocannabinol, which I'm giving a no to in terms of just say no. The cannabinoids, such as cannabidiol, which we're giving a maybe yes to in terms of some useful activities to be found out there. And then this third group, which is the synthetic cannabinoids, that's a heck no. Don't do it. This is the stuff in bath salts, etc., which astonishingly our legal and criminal justice system has not found a way to snuff, and are on the counters of many quick stops across America. These are a very variable range of synthetic congeners of cannabinoid, which can be 4 to 5 times more powerful than the strongest forms of marijuana delivery systems that you get out of plants, and they can lead to really harmful effects. And number one, anytime you take these, you have no idea where this product was made, but I assure you it was not a nice, clean, lovely lab. And you don't know what the concentration is, you don't know the exact effects, and you're putting yourself at great risk. And susceptible people can get panic, can get cardiovascular changes, can even have seizures. And at various times there are, whatever the new batch is they slightly change the formula to stay one step ahead of the law. It's very potent and very dangerous. And we urge people to stay away from these entirely. Dr. Davidson, I'll hand it on to you.
Okay, so, part, I guess, and also thinking about why are we, really talking about this today. If you go to the next slide, we can talk about the changes in the legalization of marijuana across the United States. So we know this is constantly changing, and what we're seeing is that there's better access to marijuana. So as we're seeing more and more access to it, even though a lot of your patients are already using marijuana, opening up the access here is going to really impact the amount of use that you're seeing. The FDA has actually approved some cannabis-related compounds or compounds that are derived from cannabis. Um, in certain indications. So in very debilitating disorders or conditions like the ones you see on the screen. So to treat weight loss in people with AIDS and in receiving cancer chemotherapy, really debilitating seizure disorders like Lennox-Gastaut syndrome or Dravet syndrome. And then outside of the US, it's cannabis, these kind of cannabis related or cannabis derived compounds have been approved for some other indications as well. So if we go to the next slide, we have our map showing outside of this sort of regulated, FDA approved, these other indications. Now we move outside of that and talk about cannabis itself. So in the states that you see in orange, this is where both medical and recreational cannabis use is legal. So this means whether you have a card or a documentation from your physician, you have access to the dispensaries. They call them different things in different states. So um, the dark blue states that you see there, these are the states where the only legal use of cannabis is that for medical purposes. So in those states, you would have a card or some type of documentation from your physician describing your condition, what you're using it for, and thus providing access to the dispensary. But again, those requirements differ by state, so it's a little hard. That would be a very long presentation if we went into all those details. But the light blue states that you see, so I live in one of these light blue states where cannabis-derived products or cannabis-related products are legal as long as the THC concentration remains below a certain amount. And each state has decided their own sort of threshold for where that is. So, it could be, I've seen 0.03%, I've seen 0.3%, I've seen 1% THC is allowed in different states, but the idea is very low amounts of THC in the states where they allow access to these products, but CBD is legal. The states that are in gray are no cannabis public access at all. So you wouldn't find CBD oil there, to my knowledge, if the legal aspects of this hold up.